I will start with the nursery.
Thank you very much. My name is Nasri Adam, and I'll be the co-moderator of this webinar. I'm the Director of Impact and Communications at AVPA and also manage our East Africa region. Thank you.
Thank you very much, Nasri, for that. Let's go to Julia.
Good afternoon or good morning, everyone. My name is Julia Greenland. I'm the Managing Director for Africa from the Healthy Brains Global Initiative, and I'm based in Nairobi.
Thank you, Julia. Let's go to Imke, then Shivan.
Good day, everyone. My name is Imke Engelbrecht. I am a medical doctor by profession. I've been in the public health field for about 5 years now. I am the Deputy Chief of Party for the privately funded programs at Right to Care nonprofit in South Africa, based in Centurion. It's lovely to be with you all. Thank you.
Thank you. Let's go to Imke.
Hi, everybody. I am Shiv Bhavnani, and the label on my name says I'm Eric Macharia, but I'm not. I'm Shiv. I am the founder of the Global Institute of Mental and Brain Health Investment and a partner at Evio Venture Capital, which is a mental health focused investment fund. I'm excited to be here today.
Thank you very much, Shivan, for that. And now to the program on the next slide. We will have our panelists share great insights with us for 10 minutes each, which will be followed by a 20-minute Q&A session, and then final remarks and call to actions. And to my setting of the stage, before I call in our first speaker, I am excited to mention that this is only the first of a series of webinars on mental health financing that we'll have. Please do keep an eye on the next set of information from AVPA. We will be sharing more information on the series in the next few weeks. To set the stage from my side, mental health, on the next slide, mental health remains critical yet underfunded global challenge with gaps in access as well as sustainability of the services. We have seen traditional financing models focus on inputs rather than results. This has often led to inefficiencies. Now, during this webinar, we will do 3 things. Number 1, we will examine how outcome-based financing transform mental health funding. Number 2, we will share a case study of the successful and ongoing implementation of outcome-based funding model. And finally, we will learn some of the examples of outcome-based funding innovation opportunity areas in mental health and some of the gaps that still remain. Before I call the first speaker, let's have our first poll question on the screen. And please, our participants, do you have, please take a minute to answer our first poll question. For those responses, this will be very valuable to us in the webinar report that we will begin to share. Now, to our first...
Sorry to interrupt you, Dr. Pon. It's a bit faint. If you don't mind moving a bit closer to the mic or increasing your volume, please. Thank you.
Thanks. Thank you, Nasri, for pointing that out. And now, allow me to call out our first speaker, Julia. Julia, you have done great work around outcome-based finance. Could you walk us through what outcome-based financing in mental health means and how typical mental health outcome works from investor to service provider, and how such models can help transform mental health funding? As Julia comes in, our poll results are so out. We are seeing a majority of people talking about investor skepticism as one of the biggest barriers for outcome-based mental health funding in their work. We will share this together with the report. Now to Julia.
Absolutely. Sorry, should I be controlling the slides? Would you like me to?
No, let's go to the next slide for Julia.
Yes, perfect. Thank you. Excellent. Yeah, we can get
Next
started
slide.
on the slides. Perfect. Thank you so much. Excellent. Thank you. And I'm so pleased to be here, and it's so great to have this this platform with AVPA and the other partners. Can we go to the next slide? Great. Now I won't belabor these points because I'm sure many people on this call are already very well well versed in them, and of course many of you are already experts. But just to emphasize that mental health is a truly global challenge. About half of people in the world will develop a mental health illness over the course of their lifetime. And despite the massive and growing scale accelerated by the COVID-19 epidemic of mental poor health, it's an incredibly underinvested in area. Only about 2% of national health budgets go into mental well-being, and it's similarly a very small but indeed growing area of philanthropic and development spending. The part of the problem in advocating for additional resources going into mental health is that, of course, those conditions are wildly underdiagnosed, both due to stigma that prevents people from seeking treatment and care and diagnosis, but also because many of the tools that are used to measure poor mental health are developed for Western contexts and are not often well accepted or or widely used in developing contexts. Can we go to the next slide? Next slide, please. Yeah, great, thank you. And all this has led to the global crisis. If you can go back one, sorry, to the side with the girl in the blue shirt, in the green shirt. Just to emphasize that the mental health crisis is worse in developing countries, from at least from what we know. Sorry, are we able to go back to slide number 3, please? Great, thank you so much. So indeed, in developing countries, mental health remains the #1 cause of disability. People who suffer from poor mental health are often locked out of treatment and economic opportunity for much of their lives. This is all exacerbated by a lack of human resources for mental health. The WHO estimates a shortage of over 1 million mental health workers across low and middle income countries. But in many ways, that also that's a narrow way to look at poor mental health. Many people who struggle with poor mental health do not necessarily need access to a mental health doctor. But there's still a massive gap, and despite efforts to bring mental health care closer to the community, it seems that there remains a very large gap, both for people who are seriously mental ill and people who have mild and moderate mental illness that may not necessarily require pharmacological or psychiatric treatment. I'm seeing in the chat that some people are struggling to see the slides. I'm sure the AVPA team are taking note. And it's worth noting that while we lack a population level data on the prevalence of mental illness, both in Kenya and South Africa and many other low middle income countries, the social determinants for poor mental health, such as poverty, exclusion, stigma, differences in the rights between men and women, are all higher in many developing countries. So we can anticipate that there are very high levels of mental suffering, really, in developing countries. We can go to the next slide, please. Now, how can we begin to address what seems like a really insurmountable problem? Well, at HPGI, we really believe that part of the way that we can address this is by looking at the interventions that we do have and the interventions that are being developed. And there's been a great explosion in the number of innovations and the number of resources that are available for improving mental health. And moving the way that we manage those from the traditional pathway of counting inputs, so the number of, say, trainings or counseling sessions that are delivered, and instead shifting focus and resources to outcomes. So this is something called a results chain. It's not so dissimilar from log frames or other theories of change formats that you may have seen. But the idea here is to split out the way that programs are delivered into their inputs. So what goes into the program, the number of activities, the outputs, so the thing that happens immediately and logically after that. So for example, someone, if an input is delivering a community health intervention, the output is then people completing that intervention. And instead go one step further to really consider, well, what are the outcomes that we want to be delivering? Now, it looks very different from some traditional donor programs, and we'll talk about that more in a minute. But I think the main thing that we want to emphasize here is the importance of moving from considering success to be a certain level of things delivered, and instead towards a certain number of people who are experiencing a better quality of life, for people who feel supported, people who are cured, people who are able to re-enter parts of their lives that they may have been prevented from experiencing when they were in poor mental health. So when we think about what goes into a good outcome for this sort of programming, there's four areas that we like to look at. So one is that it's quite easy to find outcomes that are globally have been globally created, that have been created in places like London or New York or Geneva. But we really want the outcomes that we manage to be locally relevant and resonant. And this is something that you'll hear a lot about in Imka's presentation, which is coming next. So we want outcomes to mean something both to the people who experience the impact, so to the people who are actually being treated, the people who are actually being engaged to reduce stigma, for example, and to the people who are delivering it. So that means everyone from the program managers to the donors, all the way to the frontline health workers. And it should be something that all of them can understand, and all of them can relate to when considering what improved mental health is. Outcomes need to be timely. So I know many of us have probably worked on programs where where things are measured through population-based surveys, for example, or an RCT. All of those create really, really useful and often very catalytic kinds of data and knowledge, but they're not ideal for programs being managed to outcomes, and that's because they need to be timely. So if you need to run a huge survey to find out your progress against an outcome, it's probably not a great one for an outcomes-based contract. That is because you want it to be useful for management information. So it needs to be something that you can look at regularly enough, that you can see change in regularly enough, and then you can build management actions around improving. It should be systemic, so it should really count more than one thing. It shouldn't count somebody's, say, just somebody's, I don't know, attendance at a training or a single data point. It really should show an improvement that reflects the success of more than one element of the program. So for example, somebody, as you'll hear in Inga's program, who's a mother who's maybe experiencing less social stigma, more clinical support, who feels that her mental health has been taken care of at every part of her clinical journey, that is reflecting a systemic improvement in the world around her, and that's what makes it a good outcome. And ideally, it should be integrated. So there's no need to build an entirely new system to capture outcomes on top of other M&E that you may already be doing. It should be something that is cost effective and can be measured through existing channels. Can I go to the next slide, please? So what does this look like in practice? So what I'm showing you now is a very typical development sector contract. So there's usually someone who's a commissioner, so say a donor or a government, and that donor or government contracts services from a service provider. So let's say that's an NGO or a private company or someone else that's delivering services on their behalf. Those two organizations, without necessarily input from the final user, decides what's going to be delivered, and in order to get paid, or in order to be successful in their program, really the service provider just needs to show that they did what they said they were going to do, and the actual service user is rarely included other than as a sort of study subject in this ecosystem. We can go to the next slide. Now, an outcomes-based contract can work a bit differently. So here you of course have a source of funds, which is often an outcome funder. Those funders provide funding to service providers who deliver a service, and only when that service is verified and the person the person who has received the service has been included, can the outcomes funder release those funds. Now, many of you will have heard of outcomes-based contracts called development impact bonds or social impact bonds. And an element of that is that there's usually a separate investor. That's not required for a outcomes-based contract. Almost any contract can be moved to being paid on an outcomes basis. But when there is a gap and a need for for working capital, there is you have an additional player, which is the investor. Now that investor takes some of the risk off of the service provider. So if the program doesn't work, for example, it is the risk of that failure doesn't fall entirely on the service provider, but instead on the investor. And it also means that there's an investor playing a more active role as a performance manager, because of course they want to recoup their investment from the outcomes funder once the services and indeed the outcomes have been delivered. We can go to the next slide. Now, I think it's worth noting that while these models are relatively new and relatively rare in the development world, they are certainly not rare globally. In fact, there are many, there's countries like Australia and the UK that have at times run big parts of their social services through outcomes contracts. So for example, all employment services in Australia, many previous employment services in the UK, quite a number of programs in developed countries are run on this basis. And why does it work when it does work? I won't go through, of course, everything on the slide, and these will be shared later. But part of the overall story is that it really creates an ecosystem where the person who's receiving the service is at the center, and that person is able to be a kind of active part of what makes the entire program work, rather than the program being delivered and paid for, regardless of whether or not that person experiences the outcome that we initially anticipated for them. It means that the incentives are aligned behind that person's success. It changes the culture of performance management within the service providers, so that they are aligned around that same outcome actually being delivered. The risks are aligned around something that is actually meaningful. So I think many of us have probably seen programs or even worked on them where the program experienced some or another risk, but that risk didn't actually affect the impact on the final user. And at least with a contract that's organized this way, whether or not the program was successful really depends on whether or not it was delivered for the person. So it means that the entire system can move to be much more person focused. It means that the service providers, rather than delivering against a very centrally designed and sometimes quite dogmatic definition of their success, instead have a great deal of flexibility, because they're aligned around the final outcome they want to deliver, but they have a great deal of flexibility. They don't need to be delivering against receipts or against an exacting work plan that is to be delivered regardless of its impact on the final user. You can move to the final slide, Ryan. Great. And this is the reason why I think I think this area of work is so important. I think most of us have worked in development or in adjacent sectors. We've seen programs that are delivered sometimes at huge scale and often without the direct input or the direct involvement of the people who are actually receiving the services. And I think that mental health, with this place that it's in, where it's just starting to get some of the resources that we hope will ramp up to the size and scale of the challenge, we're really at a precipice, and we can go the same way as many other health areas before us, where we look at people's success or failure in a very narrow, disease-focused way, or we can look at the outcomes that actually matter to the final users, and we can be building our systems, we can be building our implementation, and we can be building our vision of success around that. And with that, I think it's a beautiful place actually to hand over to Imke, who is delivering a program that is delivering so much of that vision.
Thank you very much. Thank you very much, Julia, for that presentation. Before we go to Dr. Imke to give us how this now works in practice, please let's have our second poll question. Then we can have Dr. Imke come in. Poll question? Let's take a minute to answer this, then we can understand how OBF now works in practice, having understood the importance of making these programs people-based, people-centered. And allow me to now welcome our second speaker, Dr. Imke. I know you have a wonderful locally driven outcome-based financing program going on in South Africa. Please come on board and tell us about how this initiative, what this initiative is about, or what has made it successful, and some of the lessons that can be applied elsewhere other than SA. Welcome, Dr. Imke.
Thank you so much, and thank you once again for the opportunity to be with you all today. Yes, I am very excited to share some of the experiences that we have made with this, to us, very novel way of implementing. And yeah, we are quite excited to share that as Right to Care here in South Africa. So today we're going to have a look at a program that we actually started implementing just over 2 months ago, so it's still very new. And when I start sharing some of the initial results, you will see that we're just getting started. But I think in the context of today's conversation, it's really about how do we shift towards outcomes-based contracting, and that this is a very exciting and a novel approach that we as an organization are very proud to have been chosen to be a part of through the HPGI and our partnership with Anglo American. So we can get to the next slide, please, just so that I can give a little bit more context on this partnership and how this came about. Okay, so the name of our program is Mawanete, and I will get a bit more to that. But let me first introduce the organization that I represent, which is Right to Care. You can just go scroll. Sorry, there are some animations on these slides, so you can just scroll ahead. Ooh. Sorry, can we go back to, sorry about that. There we go. Okay, so you can just stay right there. So Right to Care is a public health non-profit organization in South Africa. We have been historically predominantly PEPFAR funded. So the main focus of our work is in the HIV, TB space, care and treatment, as well as prevention. But why this matters is that for us, this opportunity to go into outcomes-based funding came off the back of a partnership that we started in 2021, which was our first privately funded program in partnership with Anglo American. Anglo American, I'm sure most of you know, is a large mining company across the world, but also with quite a large footprint in South Africa. So we partnered with them in 2021 to co-design and develop the Community Health and Wellbeing Program. As part of this, one of the big needs that we identified was the mental well-being of mothers, especially because this came off the back of a program called Jandiri, which started in Zimbabwe, but which we've contextualized to the South African context, and really found that young moms and moms overall really need support. And that's where the idea came for this maternal mental well-being program. We then partnered, something that we are very, very proud of, with the Healthy Brains Global Initiative, and they really introduced us to outcomes-based funding. And it's also through that partnership that we were invited to share our work today. So we can go to the next slide, please. All right. So once we partnered with the Healthy Brains Global Initiative through the support and the partnership of Anglo American, we were very lucky to have HBGI as the experts in outcomes-based funding. So their role was really to guide us in the shift from making that mind shift from traditional input-based funding to outcomes-based funding. And what was really new and what was really exciting about this whole process is that we actually co-designed the entire project and not only the contract. So there was no existing maternal mental well-being program that we went in with a fixed idea to implement. We actually co-designed the project, and based on what we found, we then designed the contract, which again, I think speaks so much to what Julia said about making sure that whatever it is that we're implementing really speaks to the needs and the wants that the communities are looking for, that we are implementing the program in. This, of course, also allowed us to ensure that everything is aligned better. So the project with what the funder is expecting, with the implementation partner, as well as with the service beneficiary, so that there's good alignment between those three parties. Next came the definition and the process of defining the results chain. So Julia already spoke a bit about the results chain. I think in our line of work, we were very familiar with the terminology of a theory of change. So it really is very similar, except that you're now selecting parts of this pathway to trigger payments with. So that kind of shifts it a whole lot and makes the framework a lot more important to all stakeholders, of course. So we went through a journey, and the HBGI team again was fantastic in guiding us through this, understanding the process of the results chain, and we actually had interactive workshops. And what was great is that we had multiple stakeholders from within our organization, from the legal team to the finance team to implementers, program managers, actually join some of these workshops so that everybody in the organization could be onboarded in this shift. So of course we defined our activities, the outputs, the short-term outcomes, and then our long-term impact. And I have a slide a bit later that shows all the detail around that. What was then, of course, important, as I already mentioned, is that once we finalized our results chain, all the stakeholders had to sit around the table to decide, what are we going to get paid for? Because this is a pilot, this is a pilot program specifically that we are implementing, we did have to do some negotiating around who carries the risk. So of course, if you go in with an existing program or project that you know which outcomes you're going to achieve, or which your outcomes and impact you're going to achieve, because it's based on something that you've been doing for a long period of time, it is then a little bit easier to shift the risk more to what we call the right of the results chain, so more to the impact and the outcomes. But because this was a pilot and we were all novel to it, we were quite it was quite important to negotiate that the risk is balanced between all the stakeholders. But what was very important is to ensure that every outcome is meaningful and measurable and identifiable. Okay, so let's quickly go through what we then discovered, designed, and what we are implementing. So we went into the community. So we went into 2 districts in Limpopo, which is one of the inland provinces of South Africa, and it also borders some of our neighboring SADC countries. So it's quite a big, diverse province. And we wanted to find out what is the mental or emotional journey that moms experience, and where do they feel they could be supported more? Where do they feel that maybe their mental well-being can be assisted and supported a bit more? So we found out a lot during this discovery phase. It was all about people, about preparedness, about emotional awareness, and actually the lack thereof. A lack of emotional inquiry was a really big talking point, isolation and loss. So what came out of this discovery phase was really an emotional journey of what are the emotions that moms experience in the time leading up to the birth of their baby and the period thereafter. What we found, which was quite interesting, is that there's a significant difference between younger moms versus older moms in terms of their emotional journey. But the most overwhelming response was that nobody actually asks how these moms are doing. So the emotional inquiry, or the lack thereof, was one of the biggest things that we identified, and one of the things that we identified as being quite easy to address, low cost and with low resourcing. We could help and assist mums and expecting mums to identify their emotions a little bit better. So through that, we then embarked on the design phase, which was really about mapping the mom's journey from where she is right now through the interventions that we are planning to the place where we would want moms to be, which is a place where they feel well prepared for the delivery of their babies, and also feeling as though they can identify their emotions. If there are positive emotions, hopefully to keep them that way, but also if there are difficult emotions, to firstly know that that is normal in the antenatal and postnatal period, but also to help them navigate that with very easy to use tools. So we then developed an app, co-developed that with Demaji Comcare. This application is set to help our mother champions who are now employed in the facilities to track all the moms that they are supporting. And then we also have, excuse me, two collaterals. One is an emotional wheel, which really helps the mother champions as well as the facility managers to help moms identify their emotions, and then also help them deal with those emotions through practical steps. Then we also have Mama Muki. Mama Muki is a little booklet which guides moms from the journey of discovering that they are pregnant all the way to the first couple of months after birth. So that was basically the design phase, putting everything together, developing the application, developing the collaterals. And then came the really exciting part in mid-March this year, where we onboarded our 8 mother champions. They are peers from the communities that we work in. They have lived experiences in the sense that they are all moms. And they are now employed in the facilities and in the communities to support moms during their pregnancy and in the first few months of the new baby's life. They are absolutely fantastic, and we are very excited to share some of the first results of the work that they're doing. We can go to the next slide, please. All right, so this is the results chain, which I'm absolutely not going to go through. But basically, out of that chain, we have identified four key points that touch points at which payments will be triggered. So as I mentioned, because it is a pilot, it is a little bit more balanced, and also we have two results, payment results triggers in terms of the activities and outputs, which are slightly easier to achieve on the implementer side, and then we also have payment triggers, one under the outcomes and one under the impact. So essentially we get paid on reaching the targets in terms of how many moms are enrolled in the program, how many postnatal check-ins have been done with the mom. So those two are the ones that we have more control over as the implementer. Then the outcomes that we are paid on, the very important co-defined one that was very important to the communities in which we did the discovery phase, was moms knowing what to expect during their pregnancy, delivery, when the baby arrives, and also them wanting to attend antenatal visits. So that's really shifting the dial on moms that are completely unprepared to moms that now feel more prepared and excited about the coming of their baby. And then lastly, the impact that we are paid on is the improvement in mom's postnatal visit rate within 6 days. So that is a DHIS indicator in South Africa, and it tracks whether moms come back into care after the delivery of the baby. This one at this point has the lowest weight because of the pilot, and also because there's the least control over that specific one. But we did want to make sure that through the program we can also track and show impact to the Ministry or Department of Health by making sure that we incorporate one of their tracked indicators as well. We can go to the next slide, please. Okay, so these are just, again, the paid results, so we can go one further. All right, I think what we're going to, I think I said a lot about this already, about how important it is to make sure that the payment logic is aligned to all the stakeholders' expectations. So we can go on to the next two slides. All right, perfect. I think let's just quickly go to the results slide, then I can show you some of the work to date. Perfect. All right. So as I mentioned, we started the implementation of this program toward the end of March. To date, we have enrolled 837 moms out of the 911 eligible moms in the facilities that the Mother Champions have come into contact with, giving us a 92% successful enrollment rate. This really highlights, firstly, the need for the intervention that we're bringing, as well as, that it's absolutely an overwhelming need, and that most moms that are being offered this service choose to enroll in the program. Then we also, if we just move on a little bit more so that the other graphs can come up as well. We can see that at enrollment, most of the moms that are being encountered are still pregnant, and that is because most of the encounters are currently being done at the antenatal clinic. But we also have enrolled some moms who have already given birth, which accounts for about a quarter of the enrollments. And unfortunately, we also found that stillbirths and miscarriages contribute about 2 to 3% of the enrollment. So we did tailor some of the questions that we ask the moms in terms of the experience and the experience that they have from the program, to also be relevant and contextual to moms that have to deal with these unfortunate losses. Then we also look at the emotional identification at enrollment, and as you can see, predominantly the moms are reporting positive emotions, with only a very small component being your negative emotions. So what we are interested in seeing as time progresses is whether more moms will be willing or will be able to share that they're also experiencing tough emotions, and also whether moms are better able to differentiate from just happy or just stressed, and actually differentiate into more specific emotions as they get told more about different emotions and how to identify them. Then just in terms of the performance paid results, we can see that we've already achieved more than 25% of our target in terms of enrollments. Of course, in terms of the postnatal check-ins, we are starting to see some results there, but as most of the moms that we are enrolling are in the antenatal period, we expecting that this will follow a little bit slower, and as time progresses, we will have more of the moms delivering their babies. So then we will move toward those paid targets as well. And then, yeah, the last part that we found quite interesting is that this is also enabling us to facilitate referrals to further services that are needed. And then in closing, I know my time is up. There are some lessons learned that we will share as well with the deck, but I think the most important lesson for us as an implementer is that there really is a lot of growth, and there's a lot of opportunity in these novel financing models. And as an implementer, it's been an incredible privilege to be taken on this journey and to capacitate ourselves to also be able to say that we have been part of the contract negotiations and the implementation of an outcomes-based funding program. And we are very excited to share further results of this project in the near future. Thank you.
Thank you very much. Imke, for that presentation. I know we will still come back to this during our Q&A. And for now, we want to explore some other existing opportunity areas where we can apply OBF in mental health. But first, let's quickly go through our poll question number 3. Let's take a minute to respond to this. Then we can have Shivan speak to us about some of his ongoing work around social impact bonds and existing innovation opportunities for mental health. Allow me to call Shivan to this conversation now to share with us his experience. Shivan, I know you have been doing some great work around. Could you walk us through some of the outcomes?
Apologies, Dr. Pon. We cannot hear you. You might want to take that again.
Thank you for informing me, Nasrin. I am calling on Shivan to now walk us through what has been able to work in terms of innovation opportunities for mental health and some of the gaps that remain to be addressed. Shivan, over to you.
Thank you, Dr. Shadrach and Julia and MK for the incredibly informative presentation so far. It's a lot of inspiring work. Just a quick background on me again. I founded the Global Institute of Mental and Brain Health Investment, and I'm a partner at Evio Venture Capital. We focus on early stage investments in mental health. So, I'm coming more from the startup and venture capital world. A lot of my time is spent on innovation and technology in the mental health space. And so today I want to share some ideas and some food for thought on innovating in social impact bonds, but more broadly, outcomes-based financing for mental health. Can everybody hear me okay? Just checking the levels. Okay, great.
Yes, you can.
And some of these ideas certainly build on some of the stuff we've talked about, so far. So I really want to explore how innovation technology can integrate into traditional outcomes-based financing frameworks. So just as set the context a little bit, the SIB, or the social impact bond concept, is only about a decade old, and it's only one version of outcomes-based financing. And because it's only 10 years old, it's like any startup idea, it's still evolving. So big picture, our goal is to make all these partnerships work better for all parties and improve mental health outcomes. So when we consider the structure, we have outcome payers, investors, service providers, different intermediaries, we have evaluators, and I want to highlight just where some of the innovation is needed and could be possible. So, if we address the role of outcome payers first. I think we could start off with that. So the outcome payers are basically folks who ultimately pay if outcomes are achieved, of course. Now, like we covered earlier, these entities are typically government agencies, sometimes philanthropic outcome funds. They care about getting results, like, let's say, improved mental health, employment, reduced hospital use, and they're focused really on value for money. And I think one of the big areas of innovation could be how outcomes are defined and paid. So, traditionally, many SIB contracts set binary targets, like, for example, a 20% reduction in depression symptoms or X number of people employed for 6 months. And if you hit that target, the outcome payer pays, often a fixed amount. And in some contracts, not all, but if you fall short, you might not get any payment. There is either stepwise functions or some type of binary payments paid. So, and this is not for all, but this makes it slightly risky for investors and can discourage participation in structures like this. So, I think, and this is, obviously been implemented already in some contracts, but if we can graduate and we can move to a more continuous or graduated outcome payment structure, that means, let's say, the outcome payer can pay proportionally to the level of success. Instead of no payment unless a 20% improvement is achieved, the outcome or the contract could say, okay, we will pay 1,000 for every 1% improvement in XYZ metric. Now, this creates somewhat of a graduating pricing model. And so more success, more return. So, but even partial success, say, the service provider is using a framework which is slightly experimental, if partial success should yield partial return. And I think that models like this could really unlock more capital because you really have a better risk reward dynamics. So, why? It's because, the investor doesn't face a scenario of potentially losing everything. So big picture, I believe, with graduated payment models, you can basically have outcome pairs that attract more investors. Now, this is all based on, if you think about this, if you want to do graduating pricing models, you need continuous or more granular tracking of metrics. So these metrics could be engagement. It could be, when you start a job sustainment. It could even tie to more clinical metrics like reduction in PHQ-9 scores or GAD-7 scores. You could have, or, even more granular, you could actually have biomarkers, digital or biological biomarkers, which are measured. Now, I think that the graduated framework is a little more nuanced, and I think this could be really important. Now, like I said, you really need more detailed data dashboards, reporting, and metrics for something like this. And that's where I think technology can really play a huge role. So as an investor, more on the venture side, we're seeing unprecedented levels of tracking of metrics and outcomes in the healthcare space. But there's a big gap between what's happening in, let's say, the for-profit venture startup world and that technology being applied in, let's say, the context of outcomes-based financing. So I think there's a huge opportunity there to take some of that tracking and measurement, apply it in the outcomes-based financing world, and then you can unlock more capital via continuous payouts. Okay, so we discussed how this can, it really affects outcome payers. Another idea I have, and I want to be mindful of time. There's a few other ideas I have, but another idea is tranching risk. So before I was in the venture capital world, I worked in the finance world in structuring catastrophe bonds and other forms of structured finance, which are not now being used for climate change and many other impact areas. But the general concept behind like a structured bond is that you can have 2 or 3 different layers, and the losses, let's say outcomes are not achieved or only partially achieved, losses would hit the bottom layers before it hits the top layers. And of course, this is not totally a new idea. This is being implemented to some degree, but to structure and administrate and basically have a tranched model like this, it involves a lot more analytics, and it's just a little more sophisticated in the structuring and analytics you would need. So I think that's another idea of, on the investor side, if you can tranche or layer the bond, you can unlock more capital. Let's say the first loss piece could be taken on by an institution which has more appetite for loss, let's say more like a philanthropic organization. But imagine if you could have, let's say, an impact investor or an investor which is partially impact driven, but does want financial returns as well. You could have a protected or like a senior piece of the bond, which is protected by the first loss piece. Still want to be mindful of time, but this is the last kind of idea I have in terms of innovation. And we've been working with a few entities to find a way to integrate these ideas into outcomes-based financing and social impact funds. But it is leveraging the extent of digital interventions. Now, MK, in your structure, I noted that there's a CBT app. There is a lot of new forms of technology that have exploded in the last 5 years, which are very cheap and can be implemented from the perspective of service providers. So if you can equip, let's say, a service provider who really understands the population, is on the ground and really understands operation, but if you can equip them with better technology and interventions, then the extent of impact you can make, I think, is greatly increased. Like a basic idea here is that there's a shortage of providers in many areas, but with basic telehealth technology or digital therapeutics, you can scale care beyond just what a traditional service provider may able to implement. So some of the ideas I've had here, I've been working on, is imagine if you have a dashboard with, let's say, 200 different types of interventions. The service provider can pick and select which digital interventions are very relevant for this population and can implement that seamlessly, versus working on very bespoke partnerships with 1 or 2 startups, which take a long time to create, let's say, an infrastructure layer, which allows you, like a marketplace in a sense, to have many different digital interventions to basically implement. There's a lot more ideas I have, but I just wanted to share some of these, and thank you.
Thank you very much, Shiv. And I know we will have this shared with the rest of our participants. I want to briefly open up the stage for the Q&A session, even as our fourth poll question comes in. Please bear with us. Let's have some questions from the participants. Please feel free to type in any questions that we want to direct to the panelists briefly before we come to a close. We have any questions in the chat? I know this conversation keeps going. There is a lot to share, and we want to make sure that we address some of these questions that are coming up. First, there is already a question from the chat that we can quickly answer. We have a question on how we can go about structuring the weights for payment. We can take 2 questions and then we can move on. Julia, do you want to take this?
Yes, happy to answer. So it's a very good question. And ideally, in an outcomes contract, one of the key things that you don't have too many outcomes that you're paying on. Most successful and well-structured programs have maybe 3 or 4 at most outcomes that are being paid on. Sometimes a outcomes-based contract is paired with something that is more like a grant to allow space for innovation. But in general, you want to have outcomes that are meaningful to achieve. So you don't want it to be spread across 10 different outcomes and allow the service provider kind of too much scope to receive full payment without achieving the overall goals. You want to select outcomes that are, as Imke referred to, a good balance of being within the control of the service provider and actually reflective of the change that is being made. So you ideally want most of the payment to be based on, say, 1 or 2 critical outcomes that really show you whether or not the program has worked. And then you find other ways of moderating the level of risk for the service provider. So that can either be by providing them with upfront capital through something like an investment, or as in Imke's case, also including some payment triggers that are entirely in the control of the service provider because they're closer to the left of the results chain.
Thank you very much.
And I should mention, because I know we didn't talk about it really in any of them, that a big part of the exercise of setting up an outcomes contract is appropriately costing the outcomes. So ensuring that the cost that the service provider is recouping for each outcome that they deliver versus working out how much it costs them to deliver that, how much the donor should really be paying for it in terms of its social value, etc.
Thank you, Julia, for that. I want to call Nasri to bring us to a close, but there's just this one question that I think Imke could quickly respond to in less than 30 seconds. And this is coming from accounting standards perspective. Chad from Western Cape government is asking how outcome payments can be defined in the perspective of outcome-based financing in mental health. Imke, do you want to quickly take this before we call Nasri to bring us to a close?
Sorry, can you just repeat? I couldn't hear the last part of the question. How can outcomes?
So Chad is asking how can, from accounting perspective, how can outcome payments be defined from the perspective of outcome-based contracting in mental health?
Would it be helpful for me to take that, Imke?
Yes, please.
Sure. So again, it depends on the mechanism, and there's various ways that this works. Sometimes the outcomes payer, if they're eager to disperse their funds, as many kind of traditional donors are, disperse funds to something like an escrow account, where it's held in trust until the outcomes are achieved. If they're achieved, then it's paid out to the investor or the service provider. If not, then they're able to recoup them. And so that they're kind of realized accounting wise that way. In other sometimes more simple mechanisms, like actually the one that Imke described for her program, the donor simply makes the working capital available, and the service provider is able to realize it against their balance sheet as the outcomes are delivered. And of course, if they're not delivered, then there's an expectation that some of that capital will be paid back to the original funder.
Thank you very much. Thank you very much for that. I know we will share this report with the participants and we will get more information on this. It is now time for me to call Nasri to give closing remarks and a call to action and next steps. As Nasri comes, we can have our final poll question on the screen for the participants to respond to. Otherwise, Nasri, please take it away.
So thank you very much for all your attention. I know we're running a little bit over time, but that's a testament that there's so much to discuss in this area and so much to unpack. So thank you so much to Julia, starting us off by just, laying the groundwork around the importance of the investment around the mental health space. The fact that this is actually something that has come home to roost. It's not something that is something 3 or 4, 5 steps removed. It is something that is well within everybody's remit right now to be thinking on, reflecting on, whether you're thinking internally in your home, in your workspaces. And thank you, Imke, so much for, just bringing it out in terms of the nitty-gritty. What does this actually take? How do you visualize the theory of impact, and how you're able to really think about those outcomes in a very tangible way? And thank you, Shiv, for obviously giving us now, the hardcore numbers. Yeah, if you're going to go talk to an investor, this is actually the kind of language, this is the kind of sort of adaptability your framework needs to have to be appetizing to those kind of folks when they're looking to investment. So we were trying in this webinar, and we hope we have succeeded, to offer you a different approach from different organizations doing really interesting things across the board when it comes to mental health investment. This is not the first. So if your sort of appetite has been triggered, this is only going to be the first of a series of webinars leading into our conference that will be taking place the first week of November from the 3rd to the 5th. More information is available on our website, avpaconference.africa. So we encourage you to look at that. We also will be we just opened a course up for catalytic capital training in conjunction with UCT, the University of Cape Town, Bertha Center. We are currently open for applications. So this is also another place to go in and do a little bit of a deep dive of what are these, we talk about capital, but capital is not the same. And we need to also recognize that not all money does, the same thing. It's not all the, all the capital stacks are not the same. So Rachel has provided a link in the chat for all of you in case that's something of interest. And then lastly, tomorrow, if you do have an opportunity, we are hosting a Dealshare Live, investing in the future of youth-led innovation across Africa, and that's at 3 to 4:30 East Africa time. And that's another opportunity, again, to just unpack some of these conversations around how is capital flowing, what are the investments, what are the opportunities, and it'll be a great opportunity for learning. So thank you ever so much to all of you. We have been curating the questions that came through in advance of the webinar and those that are emerging in the chat. And that will also inform us to now think about the next in this series, and we will continue to draw out more information. But as Julia mentioned, these materials will be available online, and a recording of this also will be available to you all. Thank you very much, and have a very lovely evening or afternoon, depending on where you are. Asante sana.